welcome to everybody. My name is Ann Merchant, and I want to welcome all of you here for our virtual event, which this week we are calling Your Brain on Anesthesia, featuring Dr. Emery Brown. And of course, joining me, per the usual, is Rick Lovard.
Hi, I'm Rick Lovard. I'm the Program Director of the Science and Entertainment Exchange, which is a program of the National Academy of Sciences, which is why I'm here.
Exactly, always. And so, not always, but many times we draw the inspiration from our events from the catalog of the National Academies work. So I think the last event that we did was on Havana syndrome, for which we had a report. We recently did an event on incarceration, for which we have a report. But sometimes the events just kind of, write themselves because they're just super interesting. They have they address more questions than there are answers, and that makes them feel like perfect for exchange territory. Yeah, that's your prompt.
There we go. I'm going. Whoops, sorry. If you are interested in some of the events that we've done in the past, you can find those on our website. If you are a writer, producer, storyteller in any format, and you have a question about science while you're trying to create a story, we can connect you to a scientist was what they're talking about. And Sachi's going to put that contact information into the chat for you. We've done this over 3,400 times, including just about every Marvel movie since Iron Man 2. We do documentaries, we do novels. So give us a try if you have a question. And if you are a STEM professional, and this is the first you're hearing about the work that we do, please do put up your hand. We are always interested in finding new people in STEM fields to connect to storytellers, and we're always looking for new people. So please go ahead and put your hand up. I want to thank today's sponsor, Howard Hughes Medical Institute, without whose support we could not be doing these events, and also the Alfred P. Sloan Foundation, from which we get major funding. And to individual donors like many of you, yesterday was Giving Tuesday. If you do have an interest in making us part of your end of your giving, we are a nonprofit. Sachi will put that link down there as well. And we are hugely grateful to our individual donors. You guys keep us on the air here, so thank you for that. Courtney, Jeff, Sachi, Ameche, thank you for doing everything on the back end and making this possible. Today, you're going to hear from a single speaker who Ann will tell you about in just a moment. But if at any time during the event you have a question, please put it in Q&A down here. And I'm going to get to as many questions as I can possibly do on the back end of this event. We usually get more questions than we have time for. If we did not get to your question, it's totally my fault, and I am sorry for that. And we'll do the best we can. For my rabbit hole this week, I have two pieces, both about the history of anesthesia, with a friend of our program, a member of the National Academy of Sciences, a speaker on multiple occasions who you may be familiar with if you are familiar with our programming, named Howard Markel. High recommend on both pieces. I hope you check out those links. And back to Ann.
Thank you. And I will check out those links because I want to. So my rabbit hole, anesthesia became especially personal to me when a member of my family had something called propofol infusion syndrome, which is a fairly rare, but also quite serious condition when you have a bad interaction with propofol, which is fairly commonly used as an anesthetic. So Sachi has placed that. It's a journal article. It's pretty heavy reading, but I think it gives you some perspective into the fact that anesthesia is not just something we should take for granted. And that's certainly something that I learned when I first heard Emery give a talk. It was at TEDMed many years ago. So the first thing I want to say about Emery is that he is what we call one of our triple threats, a trifecta member. He's a member of the National Academy of Sciences, the National Academy of Engineering, and the National Academy of Medicine. That is a rare accomplishment indeed. There are only a handful of people who have achieved those three milestones in their career. And I think I didn't know that when I first heard Emery give a talk, but what I really was struck by is that it's really amazing when you can sit in an audience, and I've heard a lot of science talks and I find them all genuinely interesting. But when you sit there and you say, whoa, I didn't know that. I didn't even think about that. I'd never thought about that. I mean, I think that's when you really are kind of lost in the moment and you want to go out from that talk and tell somebody else about it. So we are really very grateful to Emery for joining us on our stage today, because he is a bit of an iconoclast. He's not your average everyday anesthesiologist. So Emery, we would ask you to join us now, and we'd like to hand the stage to you and for you to take it from here. And again, thank you very much for joining us. We have a big audience today, and I know they're eager to hear from you.
Thank you so much. It's a real pleasure to be here, Anne. Thank you for that kind introduction. And it's a real honor and a pleasure to share with you some of these ideas about anesthesia. And as Anne said, the title of this is Your Brain on Anesthesia. And I added the sort of the byline, basic facts that everyone should know, because it's important from a medical standpoint, but it's also important from a scientific standpoint. And understanding how anesthesia works, I don't think is all that complex. And I'd like to have I think the more we inform the public about how anesthesia works, the more we can better take care of patients, but also use anesthesia as a scientific tool. So those are the ideas I'm going to talk about. So what I'm going to do is I'm going to share with you a series of about 6 or 8 factoids about anesthesia. And then after that, let's open it up for a discussion. All right. So what is general anesthesia? So it's a drug-induced reversible state that consists of unconsciousness, amnesia, you don't form memories while you're unconscious, analgesia, we take away the ability for you to perceive pain, and you're not moving around, so it's easy for the surgeons to operate. And we do this while maintaining control and stability of the physiological systems. And the reversible is important. We bring you into that state and we bring you out. And if you wanted to summarize this in just one term, it's basically a drug-induced reversible coma. You have to be in a coma so you could tolerate essentially the pain and trauma of having a surgical procedure. Now, one thing that's said is that it's not clear how anesthesia works. And the first thing I want to assert to you is nothing could be further from the truth. And I'm going to demonstrate that to you here now. You can get a very good sense of how anesthesia works. So in our patients, we can use EEG to monitor their brain states under anesthesia. And so this is I'm going to play a video here of a woman I took care of a few years ago. You can see it was back in 2013. She has 4 leads of EEG right on her forehead there. And I'm going to give her propofol, the drug that Anne mentioned. Propofol is our most used anesthetic. It's unfortunately the drug that's associated with Michael Jackson's demise. It's extremely powerful, and you're going to get a sense of that now just by watching her EEG. So I'm going to inject 150 milligrams of propofol, and we're just going to watch. This isn't edited. This is in real time. So the first thing you see there, you can see the EEG, and those are eye blinks, okay, because it picks up the muscle movements from the eyes. And now you're going to see the EEG get very, very noisy here in a second, really noisy. And that's because when propofol is injected into a vein, like a small one on the back of the hand, it burns like crazy. So watch this. See the noise coming on? See, that's her tensing up. All right. Now, that's actually going to be very, very good from a pedagogical standpoint, because you're going to be able to see precisely the moment when the drug takes over and she starts to become unconscious. This happens in another about 5 or 6 seconds here. So right here, watch this. Watch how the oscillations change right here. Boom. So those are what are called beta oscillations. Now they're going to get deeper, slow oscillations. That's her brainstem going out. So she's unconscious right there. They get even deeper. And now they're going to get flat and burst. But so not only is she unconscious, but she's also stopped breathing. So we have to take over her breathing, and then we'll go and complete the induction with an intubation and then administering the other drugs that are needed to take care of her. All right. So what happened there? So these are 2 of my colleagues, Patrick Purdon and Shun Akeju. Patrick I've worked with for a number of years now, and Shun Akeju is our new chief of anesthesia at Mass General Hospital. And I want to give you a real sense of what we were looking at there. You saw those oscillations appear. They weren't subtle. They're actually quite large. And to give you a quantitative idea, as we're just talking here now, if you measure the oscillations in my brain right now, they'd be about 5 microvolts. Under anesthesia, they go up to about 20 to 50 microvolts. And then in a kid, they go up to about 1,000 microvolts. And they're highly structured and organized. And here's kind of like what's happening. So imagine you have these two parts of the brain. Here's the front of the brain, the cortex, very important for reasoning and thinking. And then the thalamus. The thalamus is the ultimate way station. All sorts of information goes to the thalamus. Pain information, information about hearing, vision, sort of touch. And if you wanted to tie up one brain region to make someone unconscious, the thalamus would be high on that list. So you saw the oscillations appear on the EEG. And this is the way the brain would normally communicate. You have a nice sort of high frequency sort of communication between the cortex and the thalamus with, low amplitude, like you can see here in the picture here, like very low amplitude rhythms. Now, when you get the propofol, one of the things that we've sort of deduced from our animal experiments and our modeling experiments, what we just saw there changes to this, where you see the large, big, slow oscillations for one thing right there. And then in addition, you have this oscillation that goes back between the thalamus and cortex at about 10 cycles per second. And the change in size is important because now it's like going from me talking and you hearing me talk to something that sounds like, and in the latter case, there's no information transmission. So what have we said here? The anesthetics produce oscillations that disrupt how the parts of the brain communicate. And what they're doing is they're creating oscillations in the extracellular currents, and it makes it very, very difficult for the various parts of the brain, in this case I'm indicating the thalamus and the cortex, but the other parts as well, to share information with each other. And this is why people become unconscious, or one of the reasons why people become unconscious when you give them anesthetics. And then the other thing that we've figured out is that the anesthetics, depending upon their class, have different signatures. Now, you might be able to see it here. Like, for example, you see here, this is propofol, all right? Again, which I just showed you before. That was propofol that we administered to the woman in the video. This is sevoflurane. This is an ether. By the way, we still use ethers. Ether was the first anesthetic that was really identified back in the 1840s, both in Georgia by Crawford Long and in Boston by William Morton. And we still use ether today. It's widely used, quite effective. And this is ketamine, and this is dexmedetomidine. So these are various doses of these drugs. You can see they have signatures, which maybe you can discern them and see that they're different. And one of the things that our work has done is shown that if you look at them in terms of their spectra, you break them down into their frequency components, you can see the effects so much better. So this is propofol. And you can see the colors and the height of the colors on the y-axis tell you like what the frequency is. So this has a frequency of about 10 hertz. So if you maintain an infusion of propofol, you get a frequency of about 10 hertz, and a lower frequency component, which is here at about 0.1 to about 4 hertz. This is sevoflurane, kind of the same thing as propofol, but an additional oscillation in here at about 4 to 8 hertz. Here's ketamine, quite high frequency oscillation. The interesting thing about this is the ketamine dynamic you see when patients hallucinate on ketamine, or when you give ketamine in low doses. You've probably heard now for treating depression. This is the pattern that you would see in their brains as they're receiving their infusion. And this is dexmedetomidine. It produces large, slow oscillations. Now, so these oscillations are not phenomenologic. As I said, they're part of the mechanism. And the work that we've done is to go and sort of use the dynamics that we've seen, matching it up with anatomy, and coming up with hypotheses and experiments to understand how the oscillations come about. So we could take a deep dive into each one of these, but this is just to show you that it's not just phenomenology, it's actually linked to the neuroscience. And one of the pieces where this has come up recently in the popular press was back in late January, early February. Ezra Marcus, who's a writer for the New York Times, asked me to comment on the recent sort of uptick in use of nitrous oxide for getting high. And it just so happens that about 5 or 6 years ago, we wrote a paper on nitrous oxide because we discovered that it had these amazing patterns on the EEG. And it led us to speculate as to what might be happening. I mean, I showed you some large oscillations just there a second ago, and you saw the woman in the video, at least her EEG, transition from going to high frequency oscillations to these very large slow oscillations. But it turns out that nitrous oxide produces some of the largest slow oscillations I've ever seen. Not only are they large and slow, but they're also perfect. They look like a computer drew them. And then from that, it occurred to me, and the other thing too is, So that's the first part, large, slow oscillations, probably having an extremely profound effect on large parts of the brain, in particular respiratory centers. And in addition, they can come on very quickly, even with just a single breath. And this we know because we've actually recorded these during single breath inductions. For example, in a child, you can often put an intravenous line in to give them intravenous anesthesia, so you have them take a single breath of the anesthetic, and then they go out within about 10 to 15 seconds. So here are those large, slow oscillations for, it's hard to believe that this is actually coming from a human. These oscillations here, it look like a computer drew them. In fact, they're perfectly, the distance from the time from here to here is 1 second. So you have 2 cycles per second, and this is your brain on nitrous oxide. And because this can come on within 20, 30 seconds or so of taking like a huge deep breath like this is something we should not be doing. So just, it might give you this, high, but you're also playing with fire. So the other thing is the oscillations change with the drug dose, and also they change very systematically with age. So here's an illustration of propofol again, someone who's about 30 years of age. You can see the nice alpha oscillation here, about around 10 hertz or so, 10 to 15 hertz. There's a slow oscillation. Here's a gentleman who's a little bit older. He's 57. You can see the oscillation is a little weaker, but they're still quite visible there, around 10 cycles per second. Maybe it's dropped down. It goes about 8 to 12 here, and it goes from about 10 to 15 here. And then the larger slow oscillations here, the same way as we see above in the younger gentleman. Now here's a lady who's 81 years of age. She had, this is a woman I took care of several years ago. She had a tumor on her chest the size of an American football. It took the thoracic surgeons the better part of 6.5 hours to remove it. But I was able to keep her quite appropriately anesthetized by following her EEG, and I was able to give her 1/3 of the already age-adjusted dose of these drugs because I could read her EEG and see that she was, quite unconscious based on the oscillations like I'm showing you here. And not only is it important to, not only is it important to look here at the oscillations that are appearing here, but you see the profound lack of oscillations here. This is on a log scale, so going from 20 down to minus 25 here. So this very complete loss of oscillations up here in the cognitive range where you would normally be processing information. And here is the kind of the sobering part. These two gentlemen are roughly the same age. His EEG looks like his, and his EEG looks like hers. Well, we age different physically. It's not surprising that our brains probably age differently, based on how we've been treating ourselves. And probably the wild thing about it is, and it seems like, wow, why would this happen under anesthesia? Well, see, if you forget about anesthesia for the purpose of putting someone in a state so they can have surgery, and think of it more for the purpose of doing an experiment. You put in a stimulus, and it makes brain circuits oscillate, makes the extracellular currents oscillate. Well, when you're young and vigorous, you can oscillate like this, and as you get older, the oscillations slow down and have lower amplitudes. And the rate at which that happens basically, and most likely depends upon how well we've been taking care of our brain. It's sort of like only your anesthesiologist knows for sure. And you can just guess what the kids look like. So there's a 3-year-old. And there's a 14-year-old. I mean, these are not enhanced at all. They look exactly like this in the operating room. And actually, it turns out that the biggest power is actually here around 6 to 8 years of age. They have the largest amount of power. And after that, it declines over time. So one of the things that you realize is you can use the EEG to track the brain states of patients under anesthesia, but you have to take into account their age to really read it accurately. And this is part of the educational program that we've developed for anesthesiologists so they can take better care of patients. The disappointing thing at the moment is that less than 25% of anesthesiologists use the EEG like I'm talking about here. This information is readily available and easy to use, but it's not exploited. We're obliged to monitor heart rate, blood pressure, oxygen delivery, oxygen saturation, body temperature, but we're not obliged to monitor the brain. And the irony of that is that's where the drugs are having the most profound effect. If I leave you with nothing else today, I want you to realize that general anesthesia is not sleep. And so the idea that someone, in particular, tragically, Michael Jackson, could use anesthesia as a way to sleep, but it just makes no sense whatsoever. And let's just talk about it conceptually. So this is like the lady when she was lying there before we gave her any anesthesia. And as she went deeper and deeper to the states of anesthesia, you saw her transition through all of these states here, down to the burst suppression where she had burst and she was flat. And between the bursts, she was basically flat. So all of these states down here are states that you see in other states of coma. So it's not surprising that we consider anesthesia a state of coma, because the responsiveness of the patient is very much like that of someone who's in a coma because of brain injury. But you can see what we do is we give you drugs and we bring you down to the state and we hold you here. And that's anesthesia. And although these oscillations look like these over here, they're quite different. Remember, when you go into sleep, you start with non-REM stage 1, go to 2, come up to 3, and then back up to REM. You do that about 4 to 6 times a night, roughly every 90 minutes or so. So anesthesia, sleep is an oscillation between 3 or 4 different states, 3 states of REM, 3 states of non-REM, and then up into REM sleep. Whereas anesthesia, you're basically holding the brain in this set of pathologic oscillations. Here, the brain is actually working. Now, during non-REM sleep, it's approximately resting, let's just say. And during REM sleep, it's probably doing some work where it's refining synapses, probably pruning information or what have you. So general anesthesia is not sleep. Well, often when anesthesiologists come to patients, they say, Mr. Jones, I'm going to have you go off to sleep for your surgery, but don't worry, I'll be taking good care of you. I mean, obviously, you can't go up to a patient and say, Mr. Jones, I'm going to be taking care of you for your surgery. I'm going to put you in a drug-induced reversible coma. I mean, that wouldn't endear you to the patient. So what I do is I just explain the definition. I say, you're going to have general anesthesia. You'll be unconscious. You won't be aware of what's going on. You won't form any memories about anything that's happening during that time. We'll make sure you're quite comfortable, and we'll watch your physiologic signs, your respiration, your breathing, your body temperature, what have you, and wake you up comfortably and send you to the recovery room afterwards. So I don't try to shortcut it. I just explain what anesthesia is, and patients get it. Patients understand that. And I think it's very important intellectually to not just use metaphors, but to try to be as precise and accurate as possible, because that's when we're going to be most effective as physicians. So if nothing else, general anesthesia is not sleep. Let me leave you with one last idea. Very often people's brains don't work after anesthesia. And you saw how rapidly the woman became unconscious, or at least I suggested when she was unconscious, how rapidly the rhythms formed they changed when she was receiving the propofol. Well, one of the things that we don't do, we actively induce you and maintain you in anesthesia, and we just turn the drugs off and let them wear off for you to wake up. Therefore, given the rhythms that I've shown you, it's not surprising that people's brains don't work after anesthesia, particularly the brains of older patients. So one of the things that we've been looking at, in particular my colleague Ken Salt has been championing, is coming up with ways to turn the brain back on. So let me just show you this in this video here. So this is a rat which is anesthetized with isoflurane. It's one of the, like I said, the modern ethers that we're still using. And he's been there for about 20 minutes or so and breathing in isoflurane. It's a gas, so he's anesthetized by gas. And what Ken is going to do is inject methylphenidate, Ritalin, the same Ritalin we use to treat ADHD. So he has to flush it into the line. Now watch what happens. Now we haven't turned the anesthesia off, right? So whatever is affecting him is working despite the fact the anesthesia is still present. So it's having a profound effect also. And now he has to turn over for this to count. It doesn't count if he doesn't turn over. So you can see he's twisting his arms, twisting his body there, making very purposeful, intentional movements in order to turn over. Well, and he does make it. I've seen the end of the video. Here he goes here, almost. A little bit more. So he made it. All right, fantastic. So what is Ken doing? This is my colleague, Ken Salt. So what is he doing? So during consciousness, one way to just think about it kind of grossly is we have this balance between the inhibitory and excitatory circuits in our brain, that allow us to communicate, think, eat, carry on our normal sort of cerebral functions. You give anesthesia, and roughly speaking, the inhibition in the brain is much greater than the excitation. That's why the brain is in this different state of dynamics, essentially turned down, if you would, all right? Now, what Ken is doing by administering the Ritalin, it increases dopamine, most importantly, in the cognitive circuits, the ones that run from the midbrain up to through the limbic system, where emotion is sort of modulated up through the cortex, where it's a very important area for conscious processing or cognitive activities. So you have the stimulation induced in consciousness that's basically overriding the inhibition that's been placed there by by general anesthesia. And this is consistent with the idea that there are a lot of people who self-administer drugs like Ritalin, modafinil, because they say their brains work better when they're on these drugs. Again, just like nitrous oxide, something one should not do. This is dangerous. But I call that sort of science from the word on the street. The word on the street tells us that we should be doing something like this for patients, particularly perhaps our elderly patients, to help them come back so they can recover their cognitive function as quickly as possible. Because the current statistics now suggest that somewhere between, depending on what study you want to look at, 40 to 60% of the elderly patients have some sort of brain dysfunction following anesthesia. And as our population is getting older, those numbers are only going to get worse. So we have to come up with something to try to fix this. So here's what I've told you. So the brain under anesthesia, it's not turned off. It's actually quite dynamic. You saw that. And it's this dynamic, these oscillations that create the altered states of arousal and impairs, as we said, the parts of the brain from communicating. What's really cool about it is they're very easy to see. In fact, these are the strongest EEG signals that are out there among all the things that EEG is used for example, to track patients in coma, to do sleep studies, to track meditation or what have you. These are the strongest one, and we as anesthesiologists use them the least. And the EEG patterns change very systematically based on the drug you're using, the dose of the drug, the patient's age, and the patient's state of health. And I just showed you the benefits, or suggested to you the potential benefits of turning the brain back on after anesthesia as a way to speed recovery and hopefully eventually eliminate the post-operative cognitive dysfunction that we see in anesthesia quite frequently. And one last idea is that general anesthesia is an underutilized paradigm for studying the brain. And for that, I just want to leave you with this little diagram here. You know, you have this is sort of the anesthesiologist's view of clinical neuroscience. You know, we're here in the middle, and the rest of clinical neuroscience, or a good part of it, sort of revolves around this. No, but it's actually true. So just as, for instance, obviously, you know, we use drugs like ketamine to treat pain. Now it's also used to treat depression. The idea that I showed you about using Ritalin to wake someone from anesthesia, my colleague, Brian Edlow, is using that to try to wake patients up from coma where possible. And epilepsy, for example, at high doses, the ultimate treatment for epilepsy is anesthesia. If someone has intractable seizures, you actually anesthetize them. Ironically, at very low doses, methotrexate, the same drug that at high doses might be used to treat a seizure, can actually cause seizure. Or, for example, we talked about sleep. We do have drugs which mimic more closely sleep than the current sleeping medications. And in fact, if you think of the current sleeping medications as sedatives or like weak anesthetics as opposed to sleeping medication, that's actually a more accurate description of them, because no drug can make your brain go through the REM, non-REM cycles. As I was showing you there a second ago, they can put you in a sedative state and perhaps your normal sleeping mechanisms take over, but they themselves can't really induce sleep. If you think of them as being weak anesthetics, many of them are in the same drug class as the anesthetics. That's a much more accurate way to think about them. So there's a lot here that, as we think about anesthesia from a neuroscience perspective, we can use to improve patient care, to offer better ways of taking care of patients who require anesthesia for their surgical procedure or invasive diagnostic procedures. But also we can contribute to clinical neuroscience and actually draw from it to make further improvements in what we do. So thank you very much. I'll stop there.
All right, thank you so much. That was amazing. We have, as always, a lot of questions. I'm going to try to get to as many of them as I can. We have a bunch of people asking about negative impacts of anesthesia on older adults. And Quinn asked in particular about older adults versus middle age and where the line might be there, and are the impacts permanent?
I mean, that's a very, very good question. And I think that if we go back here to my little diagram here, so the middle-aged line is very fuzzy. Let me take that question first. And you can see it here like in the diagram that I'm showing. Like I was saying, this gentleman here, who's 57 middle-aged, his EEG looks like that of the younger guy over here who's 30. Whereas this gentleman here who's 56, actually a year younger than this guy, his EEG looks like the older woman. So it really does depend upon how we've been treating ourselves. I mean, you see people who are in their 60s who look like they're in their 30s because they're physically fit and what have you. It's great that we found anesthesia. Ether changed surgery overnight from trauma and butchery to an often life-saving therapy. But now we have to take the next step and build it better. And we have to build it in such a way that it doesn't have these adverse effects on the brain. And pretty much any older person, and older just depends upon how old you are, in a sense, how your brain has matured or aged, has some sort of let's say, cognitive issue after anesthesia. Very commonly, it could be just short-lived delirium for a few hours or so after surgery or what have you. Or it can last for several days or several weeks with difficulty word finding or what have you. So the only way around that is to improve the anesthesia techniques. We know we can anesthetize you, take you through it safely so that you'll survive the operation. Now we want you to return with a healthy brain. And I think that's really the objective, or should be one of our major objectives for the profession over the next several years.
So does this mean that you change your approach sometimes with patients who are more or less physically fit?
Oh, no question. So for example, like this woman I was talking about here, there's already a recommendation of how much anesthesia that she needs. And as you get older, you need less. Let's just be frank about that. The circuits in the brain need less anesthesia to sort of put them into those dynamics that will generate unconsciousness or alter pain processing, right? So we already know that. But what I've discovered is that the amount that you need is even less than what we realized, and I can see that in real time by looking at her EEG. And so this is why the EEG is so very valuable and has a lot of potential to help improve patient care. It's not the be-all and the end-all. We have to change our techniques also, but monitoring and dosing the drugs more judiciously is certainly a major step in the right direction.
Higgins wants to know about activity in the brain during yoga or meditation versus anesthesia.
Oh, that's a great question because it's quite linked. My colleague Bala Subramanian actually has a meditation routine that he actually takes patients through, and he's shown that it can reduce their anesthetic requirements. And so it's a 12-minute segment, so it's actually very, very feasible. So one of the things, there are aspects of it which look very much like anesthesia with the meditation. You get these very, very, so you have a slowing down of the physiology as you do the rhythmic breathing and sort of rhythmic controlled breathing. And if you look at the EEG slows down too. They look more like sort of slow waves like you might see during sleep. And so what's interesting is the brain may show very similar rhythmic patterns, but the actual mechanism producing them is different. So just because you see things that look like slow oscillations doesn't necessarily mean they're like the slow oscillations of anesthesia. And if anything, from what we see physiologically, people who meditate or who are quite practiced in meditating, that's probably the good slow oscillations as opposed to maybe the more pathological ones like the one that we're creating with anesthesia. So in some respects, they look quite similar. There's also an alpha oscillation pattern that you see, as well. But one of the main features is you can see that the brain, based on the oscillation, seems to be in a more rested state, and the physiology seems to be much more controlled and rested as well. So quite different from anesthesia. And actually, if we could harness that in a real way, I think that would help us take care of patients better.
So Kwan is asking the reverse of the first question, more or less. He or she, sorry, Kwan, would like you to define a young brain and wants to know what some of the anesthesia risks are for younger brains.
That's a really good question also, because about 8 years ago, there was a lot of concern being expressed primarily by basic scientists who discovered that anesthesia seemingly had very strong detrimental effects on the brains of developing animals. And then this led them to conjecture that something similar might be happening to the brains of very young children. And so a partnership was formed between the IRS, the International Anesthesia Research Society, and the FDA called Smart Tots. And the purpose of it was to sort of investigate this question. And let me cut right to the chase. So for young patients who just have a single operation, short operation, a couple hours, no evidence for concern, demonstrated in clinical trial. That's not an issue. The rub comes, or the concern comes, when you have children who have to come back for repeated operations, and they need them because they're ill, and they have something which, or they have a disease process which requires surgery. So unfortunately, you can't just say, well, we're not going to have the surgery because of the anesthesia, because they need the surgery because it's most likely going to be life-saving. So in this situation, you have this quandary. So the jury is still out on those cases there, the extent to which maybe there's some degree of impaired brain function as a consequence of undergoing anesthesia. But as I said, we're stuck. And so this is why our emphasis should be on not solely on understanding the toxicity of the anesthetics, but coming with novel approaches that turn the brain off and turn the brain back on in a more physiologically sound way, so this becomes a non-issue. And that's where the research should be going.
So we had a lot of people asking about the risks, Elaine, Marie, Val, Patty, David, to name a few, and they're interested in sort of long-term effects of anesthesia on cognition. Is it a trigger, or can it be a factor in dementia, IQ loss? One person mentioned tinnitus as well. What are some of the things that, if you have to be anesthetized many times in your life, might become risk factors?
Well, that's a very good question. So there's a large movement in the anesthesiology profession now to sort of promote brain health, right? And so unfortunately, there's very little that we can do because all we have are these crude tools to anesthetize you with. And so we can do assessments to figure out, do you seemingly have a frail brain or maybe a healthy brain for your age? Those sort of assessments can be made. But then when it comes time to actually do the anesthesia, if you're not monitoring and you're still using just drugs like sevoflurane, then essentially we haven't advanced very far since 1846. So I think there's a series of things that we should be doing as anesthesiologists to improve this. One, we should be monitoring. We should use the EEG on all our patients to try to limit the drug dosing to just the amount that's needed. I think we should be using what I call multimodal anesthesia, which is combinations of drugs, if chosen the right way, can reduce the amount that you actually need to achieve the anesthetic state. We've written about this, and others have as well. I think the third thing is what I just showed you, which is waking the brain up. Turn it back on. Don't just let it come back passively. Get those circuits, working again. And it's pretty clear that there are ways to do that. I mean, we haven't found all the answers, but there's something very important to be done there. And then I think most importantly, we need to look into the future, and we need to develop different techniques for anesthesia. See, ether anesthesia, like sevoflurane, is easy to give. You just give it and it goes everywhere and it just acts on everything. So therefore it acts in a lot of places where it's not supposed to. So while you have brain dysfunction, it makes perfect sense. It's to be anticipated. But just like we've gotten more targeted immunotherapies for cancer, we should be thinking about more targeted approaches to just turning off or inactivating the parts of the brain that we need to inactivate to generate a state of anesthesia. And in 2021, I don't think that's too much to ask for. And I think that's where the field needs to go.
So Meg asks, how common is it to wake up during surgery? And I'm going to add on to that. What are some things that may have gone wrong if that has happened?
So waking up during surgery, it's not very common at all. In fact, if you remember, I said most anesthesiologists don't use the EEG. So this is happening without them really knowing the state of your brain during the surgery. And so the figures that are most commonly quoted based on studies in the UK about 6 or 8 years ago is 1 in 10,000 to 1 in 20,000 anesthetics. So it's not a very, very common event. And what happens is there are certain scenarios where it's more apt to happen. For example, you have a trauma patient who comes in and you want to give them just enough anesthesia, but the anesthesia also lowers the blood pressure at the same time, which is what you're trying to treat as part of treating the trauma. So they get a smaller amount of anesthesia, so therefore they may have awareness. Another case is where it happens, where it's more common than not, might be with emergency cesarean section in women, kind of the same thing. You're rushing in to take care of the mother and the baby as rapidly as possible. And you want to give them, again, the right amount of anesthesia, but not so much that it also affects maybe the mom or also the baby. I would submit that if we use the EEG more, we could probably reduce that instance by at least an order of magnitude, because in real time you'd have a better sense of what state the patient was in. And because very often, many surgeries are quite complicated. You have like a liver transplant or this sort of thing, or heart surgery. And for a non-trivial amount of time, the anesthesiologist is pulled away from asking the question of, is a person completely unconscious, to asking the question, how much blood do I need to give to keep them alive? Or, what's the fluid status? Or how can I, fix their respiratory status? So at that point in time, the focus on the anesthesia per se gets distracted to something else, which has more immediate attention, when it requires more immediate attention. So it's situations like that, which can occur, particularly during complex operations with very sick patients, that may lead to cases of awareness.
So E is asking, why aren't we using EEGs in surgery? Is this a cost thing, or why not?
It's not really a cost, it's really sociology. There's a perception, a broadly held perception, that the EEG is complicated, and it's not. I mean, the patterns are the patterns that I'm showing you here, and as I said, these aren't embellished figures or anything like that. That's exactly what you would see in the operating room, and it's going to require a culture change to educate anesthesiologists to the benefits that can be had by using the EEG. So see, right now, the core thinking in anesthesiology is that it's a clinical practice based on pharmacology. To adopt the EEG, you have to have a different perspective. It's a core practice based on neuroscience. And as soon as you start asking about neuroscience, you understand the neurophysiology, how the nerve cells are acting in the brain, and what kind of things can you measure to see how they're acting, and you're led naturally to the EEG. And so that sociological focus has to change in order for us to really, because I don't want people to just recognize patterns. I want them to have an understanding, as best as we can figure it out ourselves, right, of what the patterns actually mean, and not just recognize the patterns. The same way, we know a lot about the heart, the various heart rhythms, when they become abnormal, VFib, VTAC, and that sort of thing. And we understand we understand the cardiovascular physiology that underlie them. We can do the same thing with the EEG. And I think that there's a sociological hurdle that's to be gotten over in order to make this more widespread.
So Carrie has an anecdote, waking up from a surgery, and for a time after waking up, only being able to, she had a tonsillectomy, only being able to write in Spanish to express her wishes. And she says her Spanish is marginal at best. Is this a normal thing?
I always get one cool story that's and it's really amazing. This is certainly one of them. I can't say that I've heard that one before, but again, see, this is why, if you remember my last slide here, which was this, right? There are all these cool connections. There are all these little anecdotes. I mean, think about it. Someone realized that patients who may be receiving ketamine for surgery, seemingly, and they were depressed, seemingly their depression was better. So there are all these little allegories that are sort of floating around that we haven't taken time to study systematically. This is certainly one of the more interesting and more fascinating ones that I've heard. But it also points to the fact that, as I said, looking at the brain through the lens of anesthesia, the brain and central nervous system lens of anesthesia, something which is, it's an underutilized undertaking, and I think it's something that we should do more of.
Karen wants to know if you have any tips on what one can do to prep for going under, and I'm going to go ahead and say if you know it's a week or two out, and if you know you have a few months to do something.
Yeah, well, I think you want to be in the best. You know, there's an adage that I heard a few days ago, which makes it easy to remember. Whatever is good for your heart is good for your brain. So those things you've been doing to keep yourself heart healthy are also going to be things that will help you be like brain healthy. And I think that should really be the focus. You need the surgery. And, you know, so you definitely should go forward with it. It's not something to delay, but keeping yourself as healthy as you possibly can is the best thing you can do for your brain, to have it come out as healthy as possible on the back end after the surgery.
Deb had a question, just wanted to understand why EEG is measured in hertz, which you had mentioned at one point.
So actually what's happening is the actual measurements are in microvolts. And then the cycles, the oscillations there's so many cycles per second. So 1 hertz would be 1 cycle per second. And so I have a sine wave, like I was showing you, looked like this. It went up and down. It had 2 cycles in a second, but the actual amplitude of that was so many microvolts. Those are the units.
I'm just gonna say out to everybody, I think Dr. Brown addressed the question of how permanent the dysfunction can be in elderly patients who have gone under anesthesia. But if you feel that you still have more questions about it, please add it to the end. Otherwise, I'm going to mark those as answered. So Lisa is a veterinarian, and she said that in the excitement phase in animals during induction, or she gets an excitement phase during animals in induction, and she wants to know if it happens in humans too and why that happens.
Oh, it does. It's right here. See this right here? Paradoxical excitation, right in the induction. Right there, right? And the what's happening is most of this, at least from my understanding, we've learned through like our modeling work. We haven't confirmed all this experimentally. But in the case of drugs like propofol, which enhance inhibition, if you give them slowly enough, what we see, and it's not every patient, let's say it's maybe 5–10% of the patients, the inhibition doesn't take place sort of systematically. Like if you inhibit inhibitory circuits, you'll get excitation. So it's one of these situations where you can't control where the drug goes; it just goes everywhere. And in some cases, you know, the inhibition actually inhibits the inhibitory circuits, or inhibits the excitatory circuits, so you get the state of paradox excitation. Now, and we see it also. I mean, it's very well documented. However, in the video that I showed you, when you give the drug as a bolus, like all at once, so what goes in within about 5 seconds or so, you're far less likely to see it. And if you remember, the patient that I showed you, she went right to this state of sedation right here, and then down to these states here. She passed completely over the paradoxical excitation state. So it may be the case that that's not possible in the veterinary setting because of differences in resources and what have you. But if that were possible, you'd certainly rapidly bypass the paradoxical excitation phase.
So I'm going to take Chris's question and elaborate on it a little bit. She's asking, are the oscillations always the same for every individual? And I'm going to add the caveat to it. Are there any interesting pocket cases that you can think of where some other interesting thing happened as part of this process?
Well, so my conjecture is that they are pretty much the same. If they were to come back, they would be very, very similar. All right. I have no reason to think otherwise, because every time I see 30-year-olds come in for surgery and they're healthy otherwise, the oscillations look very much the same. You see someone who's, now, one of the other caveats, we said that the oscillations get weaker as people get older. They also get weaker when you're sick. So for example, a patient that has overwhelming sepsis or like a whole body infection. And I have a 30-year-old gentleman I took care of who was in that state, and his EEG looked like someone who was in their 70s or 80s, just very, very, very profound slow oscillations. And what this probably is like inflammation, which is actually turning off the arousal systems and contributing to generating these slow oscillations. And this has been seen a lot in the COVID patients, not surprisingly, because they have like overwhelming infection, inflammation everywhere throughout the body, and in particular in the brain, most likely. So that sort of thing is actually fairly common. And when I'm giving the clinical version of this lecture, I emphasize that to the anesthesiologist so they can appreciate it. You have a 34-year-old gentleman. Here's why he doesn't look like the healthy 34-year-old gentleman, because he's got a rip-roaring infection going on, and those inflammatory markers are turning off the brain.
So Joe wants to know, he is over the age of 80 and wants to know what questions should someone in his demographic be asking of if they're going to be anesthetized.
I think it's very fair to ask them, how they're going to, what drugs they plan to use with you. And in particular, what plan do they have for you for pain management? Because one of the significant contributors to sort of this delirious state or brain dysfunction after anesthesia is poor control of pain. And if there is a way to do some sort of block, like you're having maybe hip surgery and they can do it under epidural or spinal, that sort of thing. You're having knee replacement and they can do it under like a regional block, and they can instill like lidocaine in or something like that after, or like bupivacaine in afterwards. Those would be the more desirable options, because none of that's going to touch your brain. And you'll have good pain control for several hours after the operation, and enough time to sort of transition onto more oral medications and hopefully avoid, using opioids or what have you. So, I mean, those are the sorts of questions that I would ask. I'd want to know what the strategy is going to be, and also what's the strategy for taking care of my brain while I'm anesthetized? What are you going to do? How do you think about that?
So Dawson asks if MEG imaging could provide more granular measurements, and also to that, what are some technologies in the near future that you think could change some problems of today?
So the MEG actually turns out to be so it's magnetoencephalography. So as opposed to measuring the electrical field of the brain, it measures the magnetic field. The magnetic field of the brain is extremely weak. You actually need a very special room, a shielded room with super sensitive sensors called SQUIDs, superconducting quantum interference devices, to actually pick up the magnetic field. In fact, the magnetic field of your heart is actually much stronger than the magnetic field of the brain. So unless you have special squids sitting right up close to the brain like this, you wouldn't pick it up at all. It would just be swamped out by all the other magnetic fields that are around. So from a practical standpoint, that won't help us right off the bat. I keep coming back to the EEG because, see, the perception is it's old. It was first, used in 1929, so like, oh, that's old technology. It's an old, underutilized technology as far as anesthesia is concerned. And like I said, you see those patterns. They're very reproducible. They look just like that in the operating room. And I think we should use this old technology as much as possible, exploit it as much as possible, before we run off and try to just create more expensive technologies, which, again, we'll have to calibrate and what have you, and sort of develop approaches to using. There's an opportunity here, which is, again, underutilized.
So we have time, I think, for 2 more questions. We've got about 2 minutes. Peter wants to know if you can speak to any of the rare but documented cases of people under anesthesia becoming conscious but not being able to move or communicate that they're feeling pain.
Right. So again, I find it hard to believe that in those cases, people were using the EEG on those patients. I was in the operating room yesterday taking care of a patient, and she was unconscious. It was clear she was unconscious, but then the oscillations began to change. They went from these large oscillations like down here in D and E, they started to look more like C. And it was in the middle of the operation. It wasn't clear, now I could have ignored it and said, oh, well, she's under, and I have the same rate of anesthetic flowing. She should be unconscious, but she was waking up. Something had changed and she was waking up. And that's what's happening in these cases. And most of them, I haven't heard of a single case like this where people have had EEG on and they've been documenting that, this occurring. And again, don't misunderstand me. I'm not saying that EEG is the be all and the end all. I'm saying it's a technology which has an important role to play that hasn't been utilized sufficiently. Let me put it that way. And again, very frightening. I wouldn't want that to happen to me. I certainly want it to happen to one of my patients, which is why I use the EEG with all of my patients. Could I still be fooled? Sure. That's certainly possible. I'm not going to say it's like a perfect technology, but I think it would reduce the incidence. And again, it's important to understand these are rare occurrences, but because anesthesiologists don't talk about anything else about how what they do actually works, they try to keep it mysterious, then this seems mysterious. This isn't mysterious. If these states up here are what you look like when you're awake, and these are what you look like when you're unconscious, why not give the person anesthesia until they're in these states here? End of story.
The very last question is, do you think general anesthesia is overused and used when local anesthesia could be used more broadly, from Donna?
I don't know if I'd go that far as to say it's overused, but I think that what we realize now, particularly as we've been able to improve regional anesthesia techniques quite a bit in the last few years. For example, the use of ultrasound, as opposed to before, we had to find the nerves blindly by sticking in a needle based on anatomy. We can use the ultrasound probe to actually find out where the nerves are, either in the shoulder, in the leg, or what have you, and then place the blocks much more precisely. So it's not that general anesthesia is overused. I think that the techniques for doing regional anesthesia have improved, and I think that creates more opportunities and ways to, a very legitimate way. Let's say you have shoulder surgery. You could, in many cases, have it under a block with just sedation as opposed to having a general anesthesia. So that's an advance for regional anesthesia, not an overuse of general anesthesia.
Well, I want to thank you for your time today. This is a great talk, and I really appreciate all the questions you did answer. We had over 220 questions for you.
Oh, so thank you.
It was too many for you to answer in the time we had, but man, this was amazing, and thank you so much for coming today. And
yeah, I mean, all I can do is reiterate what you've just said, Rick. And as always, we blame our inability to have Emery answer all the questions on you. And
Yeah.
Okay, I'll take it. I'm a big boy. I can take the heat. All right. All right. Thank you very much.
No, we really appreciate it. And we hope all of you will be able to come back next week. We have Tina Shaw from the Action Collaborative on clinician well-being with us to talk about clinician burnout, and Milena Govich, who has directed a number of episodes of Chicago Med, as well as other work, but in particular, because it's relevant, Chicago Med. The two of them will be in conversation talking about clinician burnout. And it's not just COVID related, and it's not just about the clinicians themselves, because this affects all of us. If our clinicians are not doing well, every time we need them, it affects us as well. So join us, and Sachi will make sure that invitation hits your inboxes shortly. So thank you again to Emery Brown, and thanks to all of you for being here, and we hope to see you next week.
All right.
great questions this week. Thanks, everybody.